Thank you, Chairperson. Hope you are able to hear me. And yes, this is an important topic, and we hardly discuss in our meetings, and it has an impact on overall morbidity and mortality. So I will just share some of my views on it. 1 in 200 cancer patients suffer from thrombosis. And if you see 1 in 10 unprovoked VTE, which is diagnosed, there might be a chance of a cancer in them. So it's very important that any unprovoked VTE, venous thromboembolism, you have to look for evidence of malignancy. The patients who suffer from malignancy have a threefold increase of rehospitalization for recurrent venous thromboembolism within 3 months as compared to the patients who do not have malignancy. And there is always a higher risk of bleeding on anticoagulants for the patients who are having malignancy. So VTE is quite common in particular cancers, for example, pancreas, HCCs, lung, lymphoma, bladder, colon, and brain, and etc. So this is also an important factor, but we have to look into it. And this is the data from the Quebec showing that those patients who have malignancy and VTE, the survival is much lower as compared to the patients who do not have VTE. So it's very important that we should look for the VTEs and try to treat them as early as possible. So what are the factors? What are the causative factors for venous thromboembolism in cancer patients? So we just saw cancer related, that there are few cancers which are quite common, like for example, pancreatic cancer and various others. Biomarker driven are also, for example, somebody has got a very high platelet count of more than 8 lakhs, high WBC count, high hemoglobin. These are also associated with increased chances of VTE. If somebody has undergone surgery or hospitalization for some other reason, or certain patients who are on some anti-cancer drugs like chemotherapy, anti-androgens, these are the patients who will again have an increased risk of VT in them. Central venous catheters, CVCs, are also very important. I will deal with that in the next 2 slides. So as age is also an important, and there are various other comorbidities. As the age advances, like you can see from the graph, that patients who have age higher than 50, there is a higher chance of VTE along with the cancer. So it is very important for us to know. Now, CVCs, because majority of our patients have some port or PICC line inserted into them. And there has been a meta-analysis which has been published on almost very large, 39,000 patients. 80 studies published last year, and it showed that overall symptomatic VTE incidence is 2.76%, and the risk is highest when the venous access ports were inserted via upper extremity vein. That means that through the PICC line. So there is another randomized, meta-analysis of 12 studies where there was a direct comparison between the central venous catheters or the PICC lines, and what they found that those PICC lines which were inserted from the from the upper extremity were 2.5-fold increased risk of thrombosis. So this shows that PICC lines are not as good as the ports. I am not a very good fan of the PICC line for that matter. And you can see the analysis over here. Upper extremity veins, if you use, there is a higher chance of VTE as compared to subclavian vein and internal jugular vein. I'm not going to much detail whether you do puncture in 1 prick, 2 pricks, 3 pricks, and there so many other things are also associated with the incidence of VTEs. Cancer management and VTE management is a very complex. VTE can happen at the time of diagnosis when the patient is receiving some treatment, or whether the patient is in remission, whether there is a progression or at the end of the life, if there is a metastatic disease. So anytime there is increased risk of VT as compared to the general population. So you have to keep an understanding because of the underlying disease. So as far as treatment is concerned, there have been a gold standard low molecular weight heparins, which were compared to the vitamin K antagonists like warfarin, what we had. And from these randomized trial, it was shown that low molecular weight heparins are better than the VKs. And if we want to do much better over the low molecular weight heparins, now the DOACs have come in. DOACs means that direct oral anticoagulants. And there have been newer oral drugs like apixaban, rivaroxaban, edoxaban, and dabi. So these have been studied in the randomized trials exclusively in cancer patients, like ADAM trial, ADSELECT-D trial, Caravaggio trial, and Focusite trials. And all these trials have shown and they have tried to compare as compared to low molecular weight heparin what is in recurrent venous thromboembolism impact and pulmonary embolism and all-cause mortality. And all these have shown that the DOACs or direct oral anticoagulants score as far as recurrent VT is concerned over deltaparin, that is low molecular weight heparin. As far as major bleeding cause is concerned, both are same, but clinically relevant non-major cause is higher with the DOACs. Typically, the patients who have a GI cancer, and I will come to that in detail. So, if a patient of a cancer with the DVT with the venous thromboembolism comes to me, and how do we look at? First, we try to find out what is the type of a cancer. If somebody has got GI or GU, these are called as internal malignancies. They have higher chance of bleeding, internal bleeding because of the DOAC. So oral anticoagulants will be little difficult in such case, and we have to be little careful. Although the newer trials have been showing that there may not be as higher bleed as compared to low molecular weight heparin, but it is important. I just mentioned about the PICC and CVC lines. Typically, PICC and CVC lines, you don't have to remove the catheters immediately. You can start on the low molecular weight heparins and go ahead. Patients with renal failure, DOAC should not be given. Patients of thrombocytopenia, we have to be very careful below 20 to 30,000. Above that, you can use either DOACs in the reduced doses or low molecular weight heparins. Another important is concomitant medications. So somebody is receiving paclitaxel, TKIs for any TKI, bicalutamide, abiraterone, enzalutamide, steroids, antifungals, antiemetics. Every patient who is receiving chemotherapy is on antiemetics. So these are the patients where there could be drug-drug interaction with the DOAC. So you have to be careful with that. Patients who are having nausea, vomiting, and having problem in taking the drugs orally will also not be suitable for the DOACs. Altered GI abnormality. Suppose somebody has undergone the gastric surgery, partial or total gastrectomy. Stomach is the place where the rivaroxaban or the oral DOACs get absorbed. And if there is no stomach, then these may not get absorbed and you will have an impact on that. So if we try to assess the cancer-related variables, patient-related variables, then the duration of the treatment should be at least for the 6 months for the patients who have a early stage disease, for indefinite duration for the patient of metastatic disease. So you have to look into the about the cost, quality of life, and the effects of the minor bleeding in such patients. So there are certain guidelines which have been issued for the management of VTEs, venous thromboembolism in cancer-associated thrombosis, and we have guidelines from NCCN, ASCO, ASH, and British guidelines, and all these guidelines are also freely available to everybody for the patients who are on malignancy and should be treated properly and evaluated properly, because ultimately it has an impact on overall mortality. Thank you very much.
Thank you very much, Jyoti. So two wonderful talks by two experts in the field. We'll quickly go to a couple of questions which popped up in my mind during the discussion. And first is to Dr. Jalali. I was just going through the data on tumor treating fields, and the data seems to it's a random. There are randomized trials with very good outcome. So, and you work in a state-of-the-art hospital. What is the restriction against using this particular type of treatment in India, at least? I was quite curious to know about the tumor treating fields, why it is not available. Okay, that's fine. Dr. Basade, nice to see you. A big question on everybody's mind is, are Indians prone to VTE? And are the foreign guidelines applicable to us?
Yeah, guidelines are guidelines. I mean, I'm sure they will be applicable, but the data as far as whether their Indian patients are more prone compared to West, I'm not sure whether there is any kind of data is available. But yes, I do see, and you obviously might be seeing the VTE is quite common in malignancies. So it's on an average around, as I mentioned, that 1 in 200 cancer patients will have some VTE.
And do you think we should have our own guidelines, or we just follow this ASH guideline, which I think the latest is ASH?
Latest are ASH guidelines. I mean, they are quite common. They are looking at whether they look at the thrombosis, whether it's an emergency needed, whether like pulmonary embolism, or it is a deep vein thrombosis associated PICC line or CVC. And depending on the need, you can go with the oral or direct. You can go for the DOACs or low molecular weight heparins.
Right. And in renal failure, what is your preferred treatment of choice?
Low molecular weight heparins. DOACs
You would
have
prefer
problem
that.
with the excretion. That's where
Okay.
low molecular weight heparins are preferred.
You prefer that. Okay.
Yeah.
Nice to know that. Yeah, I think we have covered most of the points very nicely. So I thank the organizers for this two wonderful
Thank you.
sessions, and over to you, Jyoti.
Thank you very much again, Dr. Basade. It was a great talk on a very unusual topic, very, very common in clinics. And thank you, chairpersons, for this excellent session, as well as Dr. Ajit for wonderfully taking a very crisp also.